Everyone. My name is Siam Rezwan, and welcome to today's virtual presentation by Dr. Thomas Quinn at the 2021 Global Health Leaders Conference at Johns Hopkins University. For those of you watching the recording of this talk, today is May 29th, 2021. To give a brief introduction of Dr. Quinn and some of his work, he is Professor of Medicine and Pathology in the Johns Hopkins School of Medicine and Professor of International Health, Epidemiology, and Molecular Microbiology and Immunology in the Johns Hopkins School of Public Health, and Professor of Nursing in the Johns Hopkins School of Nursing. In 2006, he was appointed as the founding director of the Johns Hopkins University Center for Global Health. He serves as an advisor and consultant on HIV and STDs to many organizations, including the World Health Organization and the FDA. Dr. Quinn serves as Associate Director for International Research at the National Institute of Allergy and Infectious Diseases. He is a member of the Institute of Medicine of the National Academy of Sciences and is a Fellow of the American Association for the Advancement of Science. He is a Fellow of the Infectious Diseases Society of America and a member of the American Association of Physicians. He is an author of over 900 publications on HIV, STDs, and infectious diseases, and serves on multiple editorial boards. Dr. Quinn, we're so honored to have you here today. I'll now go ahead and give you the virtual stage.
Great, thank you very much for that kind introduction, Simon. It's a real pleasure to be with you all. I was asked to give a presentation on sort of how I ended up in global health. It's going to be a little bit of a retrospective, but I'll bring it right up to current day. Because anyone involved in the current COVID pandemic would easily recognize what a global health challenge that is and has opened up careers for anyone that might be interested. So I entitled this talk, My Journey into the World of Global Health, because like all of you, I didn't know that I was going to be doing what I'm doing or have done for the last 3 decades. And sometimes it's fortuitous, circumstances come along like COVID or like HIV or things that you might be prepared for, but you never really know, especially at your stages right now. And so I thought I'd sort of weave sort of my history. And some of you will say that's very different than yours, and that's very true. This is just one personal kind of journey into the world of global health. And all of these start with a mentor, someone who's an advisor, someone that you can identify with. If you're in high school, there are certain teachers there that you will affiliate with or look up to. This was mine in college and graduate school. He has since passed away, but he was probably the most enthusiastic professor I have ever met. It was contagious, literally. And he taught a course at the University of Notre Dame, where I went to school, called parasitology. And you go in there and he would show you these very big organisms and tell you about the diseases they would spread and the clinical signs and symptoms. And then he was a vector biologist. He actually taught how did mosquitoes spread the disease, or how did flies, or how did other snails for schistosomiasis and so forth. It was very, very exciting. And so while in high school, I was interested in biology. I wasn't quite certain what I was going to do. But as I got into college, it was clear I wanted to go into medicine. But as I got into his class, I sort of got oriented towards, again, biology in general. And so he talked me into applying to his graduate school and being one of his students. And I did go to graduate school at that point. And I worked with him for a year and a half. This is my very first publication. Very bizarre kind of study where I was studying mosquitoes that spread malaria and filariasis. And we were looking at the genes of these mosquitoes, and we found that if you altered some of the genes, feet would be growing out of the biting parts. You can almost see it right here, if you can see my arrow. What this did, it was actually the claw of the mosquito's feet growing out of the biting parts. And what it prevented was that the mosquito could not bite. So if they can't bite and get blood, they can't lay eggs, and they become sterile. And they could not then transmit disease because they couldn't pass on their lineage. But you can see I published this article. It's #1 in my list. And I look back on those days with so much fond sort of respect for George Craig and what he did for me. I then went off after I got my master's degree. I did go off to medical school. And while in medical school, I met some other medical students who had also been at Notre Dame, but were now at Northwestern. Michael Dunn was one, Henry Turguido, another. And we started to look at malaria. And one of the malaria parasites that infects small animals, mice and rats. And we looked to see what we could use to treat them to take care of their malaria and whether that would apply to humans. Well, I finished medical school and went to the National Institute of Allergy and Infectious Diseases, and I continued my work on the spread of malaria. Malaria at the time was the #1 killer of humans throughout the world. And I couldn't study it in humans yet, but I could continue my work in mice and large rats. And actually, they have a very similar disease of malaria. And we worked out how we could actually treat that grouping. And all of this, you can see the years, this all goes back pretty far back, was an effort to actually try and take care of malaria in humans, just using a mouse model. Not shown and subsequently, I worked in non-human primates, rhesus macaques. But what you're hearing is all along after I had finished medical school was I went back to the laboratory and worked on these types of malaria models. I still wanted to do clinical disease in people and really apply my skill set to try and help prevent the spread of human disease. And so after I finished this work at the National Institute of Allergy and Infectious Diseases, I applied and went to the University of Washington in Seattle. And there I met my second mentor. Now I'm stressing the importance of mentors. These are the people that are going to guide your career during your formative years. It's really quite important that along your way, establish someone who can guide your career, even at your stages right now. It's really important. They are going to be writing your recommendation letters to go into further academic education and eventually into your career. Well, I applied and went to the University of Washington, met King Holmes, who was already a very established researcher, a full professor at the university, and we sort of hit it off. And to this day, 40 years later, we're still very close colleagues. We communicate at least once every few weeks. I know what he's doing. He knows what I'm doing. You know, it developed into a lifelong friendship. So that's my number one lesson to all of you is reach out and try and find an advisor that you trust and develop a relationship with that individual, and try and maintain it. It's really incumbent upon you personally to do that. The mentors aren't going to come along and just grab you and say, hey, can I advise you? You're going to have to go to them. And then once that's established, it becomes a two-way street. And believe me, most of these people, once they've become established in academia, this is what they want to do. They want to see young careers develop. It is something that that is very fulfilling in their mid and late career steps. Well, King Holmes said he didn't work on malaria. And he said, what am I going to do with you? Because here you are, a malariologist, an immunologist, you've had lots of parasitology training. And he was working on another organism called Chlamydia trachomatis. Now, some of you may have heard of chlamydia. It is the most common bacterial sexually transmitted disease. And it's very, very common in people from the ages of 16 up to 25, especially in women. And then it tapers off a bit. It can be asymptomatic, that is, not cause any signs or symptoms, or it can cause very severe disease, including infertility. Well, the organism, I'm not going to bore you with the science. This is more about career development. But when he said, why don't you study and work on chlamydia? So here I was after 3 to 7 years just working on malaria, and I'm being told, go work on another pathogen. And so I did. I read about it, and I learned, oh my gosh, it follows a life cycle almost identical to malaria. It just doesn't go into red cells. Instead, it goes into cervical cells. So these are the infectious forms. They get inside these cells. These cells line the urethra and the cervical lining in women, and gets inside and it starts to replicate, almost like a virus. And for 50 years, people thought it was a virus. But it turns out it's not. It's a bacterium. It has both RNA and DNA. And it replicates over a 48-hour life cycle. Same as malaria. That's except the malaria would be the red cell that the parasite was infecting. Here, these are these cells lining certain organs. And it goes through this replication cycle and can actually cause inflammation and some discomfort and pain in individuals. It can also infect eyes and cause a disease called trachoma. That's in mostly low and middle income countries. But I got interested in that because, once again, it would take me, if I developed an expertise in this area, again, into the developing world to actually see if we could help people that got infected with this disease, whether it was sexually transmitted or whether it was being transmitted via flies into their eyes. And there's a whole history to that. But my life experience, I mean, I had my plan. Here's what I was going to do. I'm going to work on chlamydia. And then right at the end of that development, I had finished my fellowship with King Holmes. I was assigned by the Public Health Service to work in Baltimore, where I still am. And it was 1981, and I started working at Johns Hopkins Hospital. And while I was there, just beginning to see patients at Hopkins as a young attending physician, these two reports came out. One was a particular type of pneumonia, but was occurring in homosexual men. And a very strange tumor that I had never heard of that was also occurring among homosexual men. So this was referred to as a gay-related infectious disease, that it only affected gay men, and that it was going to stay limited to just these homosexual men. And it was a terrible disease for them. It was invariably fatal. By the time you diagnosed the disease, they were dying of this immunodeficiency syndrome. This is one of the individuals who gave us permission for the photograph, and his family. And he passed away just 2 weeks after this photo was taken. This disease got renamed as Aedes, and you all have heard of Aedes, acquired immune deficiency syndrome. And eventually we found out what caused it, and it wasn't limited to just gay men, but it spread throughout the world. Just within a 1-year period, it started being identified among Haitians living in the United States. Well, you all know about all the issues about immigration these days. Well, go back 40 years, and we were having problems back then as well. This immigration issue is not brand new within the last few years. It's been going on for a long time, and whether people coming into the country are bringing certain diseases and should they be screened. So there was a lot of issues going from the gay men, now it's in Haitians. Next thing is it's identified in hemophiliacs, people receiving blood transfusions. Then it was being identified in infants that were born to women that might have one of these diseases. And then it was identified all within a 1-year period to female sex partners of men who already had this disease called AIDS. So you can see that as opposed to COVID, it took us almost 2.5 years to identify the epidemiology of this disease. And I was very, here I had trained in tropical medicine, if you will, in malaria and chlamydia trachomatis and all these parasites. Well, when I saw that it was occurring in Haitians, I thought, all right, that's something. Is it related to any of the diseases that occur in Haiti? So that's me many, many years ago. That was my then boss, Dick Krause, who I would say was my third mentor. And we traveled to Port-au-Prince, Haiti. So here I had been training for over a decade and had never left the United States. So this is my first trip internationally and sort of my introduction into the world, really the world of international health or tropical medicine. You have to go back in time. The word global health didn't even exist at the time. It was all called international health, international medicine, or tropical medicine. Well, we went into Port-au-Prince and we started making clinical rounds. This is a ward in one of the hospitals. You can see it's packed with people. They were just makeshift beds. And everyone was receiving infusions. This is the family trying to care for these people. Well, it showed that this disease existed in Haiti as early as 1982, 83. We investigated it. We still, at that time, did not know the virus that was causing this disease. We just knew the clinical manifestations. But we found out that some of these Haitians had been in another country in Africa called Zaire. That's the Democratic Republic of Congo. And I joined up with a few other colleagues that I had met along the way. We went to Kinshasa, Zaire. It's now called the Democratic Republic of Congo. These were the investigators I joined up with. We set up a laboratory within that and started to study the spread of the disease. This is their ward, one of my colleagues that I was working with at the time. And one of the doctors, the one down here, actually Billikapita was his name. I'd have to say he's my fourth mentor. He taught me about medicine in Africa. He kept a logbook of this strange disease they called slim disease in Africa. It wasn't called AIDS at the time. They didn't know what caused it, just people had a lot of diarrhea and wasting. So they called it slim disease. It later, once we arrived and we examined all these people, we said these people have the same disease we see in the United States. It's called AIDS. And we obtained blood. We did a clinical study. And we published an article. I showed you some of the other articles that I've been working on in the early days on malaria. Well, this was our first one working on AIDS. And it was entitled AIDS in a Heterosexual Population in Zaire. It was the first report out of Africa that actually showed that this was heterosexually transmitted and would start to become a major problem if it wasn't addressed within the future. Now, what you find out, again, this is career building, is that you meet a lot of colleagues along the way that you share the work with, you collaborate. And you cannot do global health without a mutual respect for your colleagues along the way. Very, very difficult to try and do this all on your own. Impossible, really. And every one of these individuals became my friends, my colleagues, who I still keep in touch with or have risen to higher levels in their own career. So here I am in the middle. This is Billikapita, who was my mentor, teaching me how to take care of people in Africa. Over here is Jim Curran. Jim Curran headed up AIDS for the Center for Disease Control, so he's out of Atlanta. He is now the dean of the Emory School of Public Health. This is Jonathan Mann, who, after he left in this project, went to the World Health Organization and headed up a program there. Over here is Peter Piot, who was the co-founder of Ebola and became the dean of the London School of Tropical Medicine and Hygiene in London. And I could go on almost every one of these individuals and that I became friends with, really, and made all the work so worthwhile. Because we would sit around and we would share not only personal histories and friendships, but we would share our findings on the spread of this disease. So I look back upon these days as both formative for me, but also the development of my lifelong friends. Each one of these becoming a mentor in their own right over the years. Well, you can see some of those people I just pointed out to you. The four of us decided, let's write a paper for Science and actually talk about this disease. We had obtained blood from these individuals. We sent it to the Pasteur Institute. And at the Pasteur Institute, they actually recovered the virus that causes AIDS. And they got the Nobel Prize for actually identifying the cause. And we feel that we played an instrumental role in that finding. But you can see what we said. Prevention and control of HIV should be an immediate public health priority for all African countries. And this is 1986 now. So 5 years after the disease was first identified, but only 1 year after the cause of the virus. And if I fast forward to the 90s, you can see already 33 million people were living with the virus that causes AIDS, called HIV, and we'll refer to it from here on in. HIV standing for human immunodeficiency virus. And you can see how rapidly it spread, predominantly in Africa. Of the 34 million people at that time, 23 million were living in Africa. And in fact, it started to spread among lots of young people. And we did measurements of the spread of the disease in women attending prenatal clinics. These are all pregnant women, and 40%, 4 out of 10, were infected with this virus that would ultimately kill them. And 1 out of 3 in which it would be transmitted to their infant. During those days, there was no treatment. I showed you the individual in the United States who was dying from this disease. All of these people were all HIV infected people trying in an outpatient clinic in the 90s when there was no treatment. There was nothing to offer these people. It was one of the saddest situations that one could imagine. But fortunately, treatment did come along. But before treatment did, we were seeing all these young people just wasting away and dying of this disease. And there wasn't much that we as physicians could do. And that, I had gone into infectious diseases to try and, treat people with malaria, treat people with other infectious diseases. And here I was faced with one that I couldn't treat. This photograph is probably the most poignant. It was from the New York Times. These are 3 children sitting on a grave, that freshly dug grave in which both parents were buried. So they're orphans from this disease. And they, 2 out of the 3 are infected with the virus. The only one not infected was this one. And so he has now become the caretaker of his 2 siblings. It was a terrible situation, worse than anything you have read or heard about related to any other disease, and it's why AIDS rose to the public attention. Photographs like this of an infected child born to an infected mother, not only would this child die, but the parent would die as well. I'm stressing upon this because there is such a need for people to care for these individuals that come down with Ebola or Lassa fever or any COVID or what have you, there will always be an opening for people possibly, interested in going into this area of global health or public health. So what I can tell you as a summary is that by year 2000, so 20 years ago, this disease was clearly a global crisis. Now, this is all before SARS or COVID, or even some of the more recent outbreaks of Ebola or MERS. This was dominating the health scene. And it was reversing any life gains for the past 3 decades. Because many people were dying, it was reversing economic gains. It turned the health system into complete chaos, created political instability and security concerns. I talked about the number of orphans and immense humanitarian concerns that were going on at the time. But all of you know it's no longer a fatal disease. There are medications that can be given to people. And it started in the United States, really around 1996 is when we realized combination therapy could prolong the life of infected people. And the key was to make it cheap enough and to get it out to people throughout the world. And that took the United Nations and the World Health Organization to actually come up with a commitment to address the HIV/AIDS situation. And back in 96 and 98, there was like no money available for help to reach out to people with this and to buy drugs that were coming along. But that all changed with that signing of the declaration that I just showed you. And we developed what was called the Global Fund, then the President's Emergency Plan for AIDS Relief, Unitaid came along, and so forth, up to a point where we spend about $16 billion a year trying to address the problem of AIDS. So why am I sort of focusing on AIDS per se? Well, it turns out that international response to a new disease resulted in a new term. Remember, I told you in the past it was international health, tropical medicine. Now it's being called global health. So that terminology of global health really just came into the media world back around the early years of 2000. And you can see here's Time Magazine or Science Magazine, both showing their focus on attention of global health. So what is global health? And I thought I would just take, we wrote this definition out, published it in 2009. It's an area of study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. That is what global health really is. To drill down into that, it's transnational. These diseases don't recognize any country borders. They focus on what the determinants of disease and health both are, and it comes up with solutions. It involves multiple disciplines. So you can be an economist, you can be a business person, you can be a clinician, a researcher, a nurse, a public health practitioner. All of these, an engineer, all of these factor into working together in that collaborative fashion and going after trying to induce population-based prevention with individual level clinical care. I point out, for those of you wondering what you want to do, if you're interested in foreign policy, you can also think about global health. Now, the most important foreign policy issue of our time. That was written in 2006. Fast forward to 2021, it's still the same. Who isn't talking about vaccinations for the world? It is a major issue, and I mentioned that economists are concerned about health and its provision to many people. It's not just infectious diseases. That's me. You're going to hear from other people, I presume, who focus in other areas of the world. I happen to focus on communicable diseases, but you will hear about people that focus on non-communicable diseases, whether it's obesity, heart disease, mental health, cancer, diabetes. So you don't have to focus just on infectious diseases. All of these other diseases cause problems throughout the world. And what are the determinants of these diseases? And I'll just show you a couple photographs. I mean, this is just to introduce the concept of global health. Poverty is probably the #1 factor, and social inequality. The squalor of people who are impoverished and do not access the same amount of health or care that the rich in the more protected populations. And then there's human demographics and behavior. The wet markets, where people are being exposed to zoonoses, diseases of animals, contaminated water, spread of disease, and obviously masses of population. Just look at India, and when a virus spreads there and you have conditions like this, how fast it's going to spread. And what I think has accelerated the spread of diseases, especially the communicable diseases, is international travel. This is one day, 24-hour snapshot prior to COVID of airplane routes and the number of airplanes in the air within a 24-hour time period. You can all go to Google and actually see this in animation. It's absolutely incredible. But add to that the changing climate and ecosystems, the effect that changing climate has on those ecosystems. So there's pollution, the harvesting of trees and getting rid of the forestation, more pollution in the air, and the melting of our caps, the Antarctica and the Arctic. All of you, especially in your age group, are very focused on trying to remedy this. And believe me, we need it remedied. It is a crisis. And it's not just that it's hot some places or that the water's gotten hot. It's all these factors that are impacting our environment. And again, I like to pop in some of these journals. Climate change is probably the biggest global health threat of the 21st century. This written 12 years ago. So stay tuned on that. I hope that you will become more involved in changing this. This is the global temperature from year 1000 through picking up cores in the earth and so forth, and ice cores and so forth. What the average temperature was, just zero just means no change from a normal point as of 1990, where it was normalized. So it was colder before. You can see the wide ranges of temperature, but all that starts to change in the 20th century and continues to change, this being one of the more recent measurements. We have increased now 1 degree centigrade. 1 degree centigrade for Mother Earth is a major increase. So this is Northern Hemisphere, and then there's one for the Southern Hemisphere as well. So let me just skip all those little animations. What it ends up doing is creating environments in which there's droughts and floods. It's a shifting of the jet stream, and we see more hurricanes, we see more tornadoes, and in some places, major droughts and no water, and people dying of starvation and thirst. So all of this, again, you're hearing from an infectious disease person, so I'm biased, but this is a snapshot from my boss. My boss is Tony Fauci. That's who I work for. Most of you have heard his name because he's like the face of COVID right now, and from an infectious disease perspective. But he put this together for the last 20 years of infectious diseases that have occurred throughout the world. We're not going to go into any of these right now. All of you are dealing with COVID, but there's still AIDS, there's still Ebola, there's still even countries that still have polio. We still have to worry about avian influenza, diseases that are fun to pronounce, like chikungunya. All of these, there's still tuberculosis. I'm still trying to get to the bottom of trying to control malaria. So all of these still occur. And that brings me sort of towards the end, because I want to save time if you guys want to ask me questions, or I'll put them in the chat or whatever. Brings me to last year. Last year, we never heard of this disease. I mean, it came out of China. You know, we named it SARS after the virus, SARS-CoV-2, because we had a SARS in 2003. That also came out of China, but remained mostly in Southeast Asia. But this disease was not limited to Southeast Asia. It quickly spread everywhere, 165 million cases and counting. Here is the US. You remember, this is one of the graphics from my boss again, Tony Fauci, right up to the middle of May. And you can see we had an early spring outbreak or surge. We had a surge in early summer. Then we had it in the fall. Since we've been vaccinating people since February, it's been coming down, down, down. And let's hope it keeps going down more and more. And what's causing that decline? It's vaccination. This vaccine was developed within 3 to 5 months of recognition of the disease. No one had ever developed a vaccine that fast in the history of vaccinology. Became known as the breakthrough of the year. And it's showing that it's working in the United States. But we have a long ways to go to get it to the world. And until we get it to the world, we're still going to be faced with this pandemic. So let me stop sharing. I've taken up a lot of your time, but we still have time if you want to enter into a dialogue with me, or questions or what have you. So Siam, I'm turning it over to you.
Thank you so much, Dr. Quinn, for the wonderful presentation. We greatly appreciate you taking the time to share your story, advice, and teaching us so much about global health today. So we do, yes, have some time for some questions. Students, if you have a question, please use the raise hand function and I'll call on you in the order that you appear in my Zoom. Please turn your camera on if possible. And if you're called on, please let us know what grade you're in and where you are from. Let's see, so first I have Jayla Lewis.
Yes, hi, my name is Jayla. I am a freshman from Northeast Ohio. And I was wondering, during the early outbreak of AIDS, how did cultural factors play into how the response was handled? Because when the virus was affecting mostly homosexual men, the queer community, and immigrants, how did people tend to care about that? And did prejudice affect how people were cared for?
Jayla, great question. Gay men became a pariah, basically. Culturally, there were people on both sides of the aisle. There were some that said this is God's way of saying they should die, that this was a disaster given by God because of all the sinful lives they were leading. On the other side of the aisle, there were people that cared for them. There were people that reached out and tried to help them. So you saw both extremes in society during that time. Probably one of the most interesting cases was a case of a young boy. He wasn't gay. He was about 8 years old, and he got infected because he was a hemophiliac. His name was Ryan White, and he got transfused for his hemophilia. Well, once it was known that he was infected and he was symptomatic, he was thrown out of school. He couldn't live anywhere. I mean, he went from the community to the community. People just would not befriend him. Everyone thought it was contagious by being near him. And it showed what society is capable of pure hate and fear. And the same was true of any of the immigrants that came in with AIDS. So I mentioned the Haitians. Well, all of a sudden it was the Haitians that gave it to America. And if we had better immigration policies, then we couldn't, we could have blocked this. When AIDS was first recognized, the president at the time never said its word for 3 years. It just was not accepted in the main norm. Then with time, that changed, especially when it became heterosexually transmitted. Now it was a threat to everyone, and not just to these select groups. And so that changed it a bit. But we learned a lot. We thought that would apply, but then COVID comes along, and the same inequities in healthcare are visible today. And some people not really wanting to share vaccines or treatment or whatever to other countries. So good question, Jayla.
First of all, Dr. Quinn, thank you so much for your presentation. It's really inspiring, very thoughtful, and very informative. My question is, how did you balance, first of all, pursuing your interest in medicine and then in general biology, like in malaria and chlamydia, and then later as a practicing clinician and with someone working on like AIDS?
Yeah, another good question. So my training, that was all easy because I started in grad school, and I went through college, and I loved being in the laboratory, and then I started working. But when I was doing that, although I really worshiped my mentor and his career, I didn't see myself doing that. I wanted to be a clinician. And so I did apply to medical school, got accepted, went through that, and then did clinical practice as an intern and a resident, learned how to care for patients. I put the lab all behind me. So I had a shift in my career. And after 3 years of doing that, guess what? I now missed the lab. I was clearly like schizophrenic on this. Some days I liked the clinical practice and some days I liked the lab. So I went back and did some of the lab work for 2 years. Then I said, wait a minute, why not go to medical school? I don't want to keep working with mice and rats and doing basic research. And that's when I went out to the University of Washington and learned I could do both. So I could take care of patients and do clinical research if I kept the lab going. And that's what I do today. I still see patients. I still keep a laboratory going. I get specimens from the patients, take them to the lab, do something in the lab with them, and go back. I have an HIV lab, but I pivoted it to be a COVID research lab. So I have to see COVID patients and come up with diagnostics and treatments and so forth. So you can do both. It's called translational medicine. It's taking the bench and going to the bed, bench to bedside, we call it. So it's very doable.
Thank you. Next, I see Teja.
Hi, yes, thank you so much for your presentation, Dr. Quinn. I was wondering what parallels and connections you saw in regards to the government's response to HIV and the government's response to COVID, and how which people were impacted you think influenced their actions.
Yeah, so that's that's a political answer, so I have to be careful. So watching COVID take off, I thought that the government didn't quite handle it very well. Our government, I'm talking about. We should have recognized it earlier. We should have been more upfront with the public. We should have really gotten better leadership on the control. When there was the first SARS, I didn't talk about that. That was in 2003. We controlled that. We closed the borders to people. They were screened. That happened all very fast. I thought the government did a better job with SARS-1 than it did, and that's 2003. So you'll have to look and see who the president was because they really run the show. But it didn't go very well this time around. Now, go back to AIDS. How did it go then? It was terrible. I mean, the government wanted nothing to do with AIDS. They gave it a little budget. Few people at the CDC were charged with monitoring it, trying to describe it. But the response to AIDS was really driven only by gay men becoming activists and physicians who were interested in working on it. But the government was hands off until really George Bush came into power. He actually came up with this program called PEPFAR, President's Emergency Plan for AIDS Release. It's bipartisan. Both sides of the aisle are very supportive, and it continues. And that's what provides all the treatment for everyone around the world, that and the United Nations. So it took us almost 20 years to get to that point with AIDS. With COVID, because it's been spreading so fast, we've been a little bit more nimble. And, I would say the first 6 months to 8 months were a disaster at all levels of the government. I'm not just referring to one individual, but the whole government. It just was not well organized. It's much better now. And it's partially because we learned from our lessons. We have the vaccines, we have treatment. Everything's happening faster than it did with AIDS. Hope that answers your question.
Next, I see Felipe.
Yes. Hi, Dr. Quinn. I appreciate you taking time out of your busy schedule to come and speak to us. So my name is Felipe. I am a student here in Las Vegas, Nevada. My question to you kind of goes off of another question that was asked. So obviously, a large factor of public health is having to work with people, building that trust. And, quite frankly, especially right now in this political climate, a lot of people are hesitant about vaccines and different treatments. So my question to you would be, how as a public health professional and expert, how do you go about establishing that trust with people?
That's a very important, critical question. Trust is built on truth and being open and trying to say, okay, these treatments or these vaccines may have some side effects. I'm going to tell you about them, but it's still the best thing for you. And showing them data and coming up with policies that say, if you're vaccinated, you don't have to wear a mask anymore. But if you're unvaccinated, you really should be wearing a mask. What they're trying to do is be truthful and honest. Now, the problem there is that there's a lot of distrust from the previous years, times. Some vaccines that had some problems. Well, who knows? This vaccine came about very fast. I'm not so sure. There were problems in the past. Who knows about the future? So some people are just not going to have the same trust that others will. The more effective we are in public health, in improving the health of people, the more we're going to earn people's trust. So we know it's a two-way street. I say this unfortunately, is that hardly any money was put into public health over the last several decades. I mean, some public health departments were getting fax machines rather than transmitting data via internet. I mean, it's all bizarre. It's because they just didn't have any investment from the state. And as a result, if you don't have a functioning public health system within your state, within your community, you're going to question, well, how good are these people? What do they know? So I would say it's incumbent upon us as public health researchers and clinicians to earn your trust and try and be as truthful and come up with novel ways to help improve your health.
Thank you. And it looks like we'll take just one more question. I see Rezwan now.
Hi, Dr. Quinn. Thank you so much for your time. We truly appreciate it. I'm Rezwan, and I'm from South Forsyth High School in Cumming, Georgia. A lot of people in this world fail to believe that global warming is real or actually happening. So what do you think that we can do in order to make the first few steps in order to contribute to change?
Yeah, boy, you guys ask tough questions. That's very good. Education, education, education. Be a spokesperson. Come up, when you do science projects, come up with one that focuses on science. I actually did that with my son when he was in high school. We did acid rain and built a science experiment. He won. I was so proud of him. So it's really, people are gonna, again, it comes back to the trust question. How much do you trust authorities and that are saying that there's a climate problem going on, whether it's cold or it's hot or it's stormy or there's floods and so forth? The key is you're the generation that's gonna be faced with the consequences. So your voices need to be heard. You know about, I'm blocking on her name, the woman from the young woman from Sweden, who's quite, yeah. I mean, you should be the same. I mean, I actually, you know, she got a lot of notoriety. I'm sorry that it got kind of, I mean, I'm pleased that it happened, but I think it needs to be a groundswell. You know, we need to get away from coal. We need to, you know, get away from different types of pollutants. You're going to be the generation that votes ultimately, and your action should be influenced by those votes. It's the politicians that are going to make the change. You need to influence your politicians. They do listen to their constituents because that's how they get elected. So be a voice in your community. And education, find out as much as you can. You know, find the pros, find the cons, get into debates about it, and see where you stand on the policy. Thank you for your questions. Thanks for attending as well. Pleasure seeing all of you.